Okay, so here we go. We're going to stand up here and hit the arrow at the bottom. And we'll make sure to hit our pearls of information. So, okay, what the pancreas does is gives us glucagon, and it's the excretin gland. So it gets rid of things. So it's basically like a really big filter. Can you live without a pancreas?
No.
I mean, yes, but is it as easy as living without your appendix or your spleen or no, absolutely not. It serves a very vital role, but it is something that if it's life or death, we can do without. Okay? So, if we'll flip again. All right, so we're going to talk about diabetes, and what diabetes is a group of metabolic disorders characterized by hyperglycemia caused by altered insulin production, action or combination of both. We have multiple types of diabetes. We have prediabetes, we have diabetes type 1, and we have diabetes type 2. They all have a different definition, and it's going to be very important to understand which is which. I can't find the arrows when I'm looking at it. All right, let's talk about our questions here. How do I know a patient has prediabetes? This is y'all's turn.
A1C.
A1C.
A1C and blood sugar. So just take a guesstimate at what you think the A1C would be for someone we're concerned about this.
5 or 6.
Oh, A1C.
5.96, so 5 to 6ish. At what point are we considered to be a diabetic?
7.
When you have 7. So if I'm looking at my hemoglobin A1C, what does my hemoglobin A1C tell me?
You're like 3 months.
Hell
Yeah, your average of the 3 months. It tells you what, 5, 6, or 7 or more.
I mean, it does tell us those numbers, but what do those numbers mean? I mean, it's not specifically an average of the blood sugar. What is it telling me? Is it how my pancreas is working?
They're not guessing.
I know, I like it. I like it.
Is it like insulin production or like how our bodies, I don't know. Never mind.
You know, it could be insulin production or lack of, or is it just it's very simply telling us how my body is controlling blood sugar. How am I controlling my blood sugar? So if I have trouble with high blood sugar, but I don't manage that well, this lab test is going to tell me that. So not necessarily an average of it, but it does say, hey, this person's been really good at controlling their blood sugar over the past 3 months, or it's been like, this person has been living in Vegas for 3 months now and living it up, okay? So, no, just know what is causing the difference. So, type 1 diabetic. What does it mean to be a type 1 diabetic?
Don't make insulin.
This doesn't work.
Okay, so I got about 3 different things. So, pancreas is not working, correct, but it specifically is not making insulin. Yes. So, type 1, I am dependent on insulin, or insulin dependent, which is what we think of people. That means, can I take metformin?
No. Your pancreas.
Correct. Correct. When I'm insulin dependent means I have to get insulin. What are ways that I can get insulin?
Subcutaneous.
An injection. Well, I hope subcutaneous. Yes, that's a gimme. We can do it as an injection, or what's a more common practice?
The pump? Yeah.
The pump. I mean, yes, in critical care we can give it to them IV when they're in. You're going to learn more about that in next level, level 3. But for the pump, yes, a lot of patients have pumps, and that pump tells them what their blood sugar is. It releases, a certain amount of insulin for them at a certain time, or, gauges them. Or it may even beep. Who went to the park? Julia, you were at the park Saturday. You were only level 2, weren't you? So the park cleanup, Julia was with us, and one of the other students that was with us has a pump, and he was steadily beeping, and I'm like, what is beeping? Well, he's also steadily eating some carbs because his blood sugar was too low. So those pumps give them warnings and tell them, okay, it's too low, you need to eat something. So the same thing. Okay, so type 2 diabetics. What does this mean? Who are my type 2 diabetics?
Poor diet. Yeah, poor diet, poor exercise.
Sedentary. Obese.
I don't want to take this personally. Y'all are all talking about me. So yes, we're sedentary lifestyles. We have poor diet control. Can it be genetic?
Yeah.
Or what about cultures? Do we have a higher prevalence in some cultures? Yes. Okay, very good. But basically, that means that my body's not producing the insulin that it needs. So with this, I can take oral pills, right, to help control that blood sugar. Yeah, I can do some metformin, some glipizide. Do I still need to monitor for hypoglycemia? Absolutely, yes. Is there a potential that I may have to take insulin? Absolutely, yes. I may need to also include insulin in my med cabinet. Okay, so what oral medications would I anticipate?
Metformin.
And what's the other one I just said? The what? Okay, well Bridget got lipizide. So we got glipizide in there. So pigs get diabetes. What?
I don't know. Is that what it is? Pioglitazone. What's the other one? Sitagliptin. That one. There you go.
What, Aaron?
Pioglitazone.
Pioglitazone?
Pioglitazone.
What is pioglitazone?
Something we made up.
Okay, I mean it sounds good. I like it.
This is a drug that's got pig in it. That's for diabetes.
Okay.
Diabetes. I don't know. Pigs know that.
Okay, pigs get diabetes. I'm going to have to look that up. So I say glipizide. Glipizide.
That one. Thank you. Somebody help me out. Thank you.
Yeah, we're going to have to look that one up. And it could even be on our med list. I haven't even, I don't know. We could look at that. Okay, so next question. What would I teach the patient about insulin?
Take it with food.
Take it with
We measure your blood for her.
have your meal right there on the way.
Know your
Be ready to eat. Take your blood glucose before you give it. Please don't guess, but you will see some people that'll be like, I feel like this is probably going to be enough. I'm just going to give myself that. But please don't do that. Educate your patients not to do that, okay?
So are they sent home with the sliding
That's going to depend on the patient and depend on how they're sent to receive their insulin. Will some people have sliding scales and do them at home? Yes, they will.
I didn't hear.
She asked if they'll get sent home on a sliding scale. So possibly, there is a possibility of that because, but it's just not necessarily a guarantee. Yes, Carlos?
Would you give the insulin before meal, like at a certain time frame, or?
You want to have the meal as close as possible because what you don't want to happen is let's say somebody needs 8 units of regular insulin. You don't want to give them that 8 units and then they'll be like, I'm not hungry, or I haven't ordered my meal yet, so I don't know when it's going to be here, because then you could be easily dealing with hypoglycemia. So have their food as close as possible. And I talk about ordering their meals. Some hospitals, like I think UT Health, used to do it. I don't know if Christus does or not, but you literally tell them when you want a meal and you order your meal. They don't show up with just trays like we do at SHEP and Regional, where we show up with trays at the same time. So some places you can special order like a restaurant. Okay, so what lab would I expect to be ordered? Okay, we talked about this right off the bat. Hemoglobin A1C. And let's see, regarding chronic complications, what complication, type of exam, and frequency would I anticipate teaching these patients about? Okay, we got a list here. Who wants to go? Raise your hand to share a list. Yep, Narissa?
Looking at your feet, checking your feet daily.
Check your feet daily. Okay, that's one. Who's going next? Jada? I almost said Leda. Leda, I'm giving you a new name. Jada?
Yeah.
Huh? Eye exams, very important because diabetes is very rough on the eyes.
Don't you have to keep track of your kidneys?
Kidneys, another very important organ to keep track of. Okay, so we got feet, eyes, kidneys. What else y'all got? Narissa?
Not to touch anything hot, even if you don't,
Oh, yeah,
feel it or whatever. If you know it's hot, don't touch it. I don't know.
Yeah,
Well, yeah, I mean, because of your neuropathy, but that kind of goes along with the feet. Our fingers, yeah, you got to be careful with burning, getting burns, like if you touch something and burn it. Fingers, do we worry about fingers as much as we do toes? Because neuropathy is most commonly in the lower extremities, but that doesn't mean that it's not up here because anything can happen. Yes?
I didn't mean to say that. I meant to say don't soak your feet in water. That's what we were told last semester.
Right, hot water. Don't soak your feet in the hot water. Well, I mean, because if you can't feel that it's too hot, you're going to burn your feet. And then you can't feel that you burnt your feet, so you're walking around on burnt feet. So that can grow into a lot. Okay, we also have, any other organs you can think of?
Well, they get hypertension.
Those are the big ones. Well, hypertension is a kind of a risk factor, too, for it.
What's the risk factor for it? Or
Yeah, I mean, the diabetes is not going to cause hypertension, but they don't play well together either.
well, I mean, I guess if they damage your kidneys.
Yeah.
Well, I mean, I guess if you end
That affects a lot of things too. Yeah. Yeah, but a lot of it's the kidneys. One thing about diabetes that's very important to educate our patients about is it is like a silent killer. Like it's attacking everything inside and you don't know it. Just because we preferred pizza over our broccoli. Or, soda over my water, So just those simple life choices are, I love chocolate, so there we go. Okay. Now, what do I teach the patient with prediabetes? So I went to the doctor, and they're like, we got to start watching what we're doing. What education are you going to give me? Let somebody else go. Raise your hand. Jada.
Change your diet.
Change your diet, okay. Leisha. Why do I do? Look, I'm on a roll today, and it's not a good one. So, okay, what are you going to teach me about my diet?
Let me see. Just to increase your vegetables and fruits, maybe. Lean meats.
Lean meats, which are?
Chicken, and
I like a steak.
Salmon.
yeah, salmon, fish.
Salmon, fish, proteins. Okay, what about fruits? I really like fruits. But more than anything, I like some homemade bread. Low carb. Okay. Exercise. Okay. How much exercise do I have to get per week?
150 minutes.
A total of 150 minutes, but we have, what did y'all say back here, guys?
30 minutes.
30 minutes, 5 days, 150 per week. Okay, good. Okay, so I'm a type 1 diabetic. Now what are you going to teach me? It's gotten serious now.
become best friends with your endocrinologist.
Definitely got to teach them how to monitor their glucose. What about their diet?
Low sugar.
Low sugar. What? Okay. Yeah, we got to teach them how to monitor for low blood sugar. What are signs of low blood sugar?
Like fatigue.
Oh. Cold, clammy, anxious. Yep. And we're going to treat it with, Jada? Sugar. It can either be the giant glucagon waffle tablets, some liquid sugar, some juice, piece of candy. Okay, good. What about type 2? What are you going to teach me now that I have failed my pre-diabetes education, was non-compliant with all of that, and now I'm at a type 2? What are you going to teach me about?
Take your medicine.
Please take your medicine.
We still need some monitoring, so that's why you're kicking.
Reteach everything you've already taught me. What's my diet? What's my exercise? How to monitor? All of the things that you've already taught me and I failed to listen to.
Take your medicine.
I can't just take my medicine. I got to do all the other changes too, right?
They probably won't.
Well, who knows? They might.
But no bias.
I might turn around. Okay, what is metabolic syndrome? Who can tell me what metabolic syndrome is? This is the one thing that I don't have this one memorized because it's a. I bet Miss Frazier could tell us about metabolic syndrome. It's at the end. It's the last thing we talk about.
Body can't metabolize something.
So it is combined with a bunch of different things, including elevated blood pressure, your glucose, and cholesterol. So all of these combined together tend to cause problems. So if we ignore it, then it could easily cause and lead to type 2 diabetes or cardiovascular disease. So we're going to go more into this. It's the last content that we talk about, okay? Questions about the questions? I'll tell you more later. There's a lot of words to go with metabolic syndrome, and I am, honest enough to say that that's not my stronger illness. However, these others are. So, prediabetes. We already talked about most of this. Our hemoglobin A1Cs, what we're going to be screened on. Definitely got to ask for an H&P. When I'm asking about H&P, I'm asking about the patient's past and present illnesses, right? Or their complaints. How are they feeling? What are they doing? Get all that information. Symptoms of diabetes. What are my symptoms? Well, what are my symptoms of diabetes? Yep.
Peeing a lot.
Oh yeah, peeing a lot.
Real thirsty. It's 3 P's.
So it's 3 P's, but what is that related to? What is that technically a symptom of? Hyperglycemia. So my symptoms of diabetes are going to be the hyperglycemia, and the symptoms of the hyperglycemia are going to be the 3 P's. I got to pee a lot, and I'm thirsty. And what was the third one? Polydipsia. Polyuria. Huh? I'm hungry. Yes, I'm hungry. Okay, so the next is going to talk about, do you see any highlighted? Was there any highlighted on pre-diabetes? Yep. Okay. So some special pearls to take note of for pre-diabetes is it's very important we educate the patients, right, to learn and manage their risk factors. What are modifiable risk factors?
Exercise.
What did you say, Star?
Diet, exercise.
Yep. Diet, exercise. What do I want a diet? Well, okay. Sedentary lifestyle is another one. Excess stress, go figure. What's our other bad habit that correlates with everything? Smoking, yes. And diet specifically is a diet high in simple carbohydrates is a risk factor, a modifiable risk factor because I can take out those carbs, right? Okay. And what is important for me to do once I have gotten this diagnosis of pre-diabetes? What do I want to maintain? A healthy weight. What else do I want to start and maintain? Exercise. And then, what'd you say, Priscilla?
Food choices.
Food choices, so a healthy diet. Okay, good. Now on to type 1 diabetes. So my body does not have insulin, and I gotta have insulin. So that's kind of a big deal. Things that you're gonna ask your patients is, have you lost weight recently? One of the symptoms, or one of the identifying symptoms of type 1 diabetes is the fact that they're gonna come in and they've lost a bunch of weight. Unplanned. Because, for type 1, we don't get the pre-diabetes things. Type 1 is something that it can be young, or we can even be diagnosed in our late teens or 20s or even a little bit later in life. So type 1, But we know my pancreas is not working right. So, but one of the things I notice is that I've lost a bunch of weight, and I have my 3 P's. my polydipsia, polyuria, and polyphagia. So questions that you're going to ask: are you experiencing an increase in hunger or thirst? Are you urinating more than usual? And this is basically telling me that my blood sugar's been really high, right? Okay, what's highlighted there?
What do you do if you accidentally give a patient too much insulin?
Ooh, this is a good one. What did you say? Yeah.
Glucose tablet, depending on how low you drop them.
Well, how am I going to know how low I dropped them?
You have to take their blood sugar.
You got to assess them. So, yeah. So I'm going to monitor them. If I accidentally gave them too much, I'm going to monitor them for signs and symptoms of hypoglycemia. But I'm going to have ready the, either the glucagon or whatever it is that the protocol calls for. And then because I work for an organization and I did that,
You got an incident report.
you're going to do that's a medication error, so you're going to report it. And we're humans. We make errors.
Assess for.
But, that's kind of sad.
But you are going to assess, yes, absolutely. You're going
That's kind of sad because that's like 2 people made errors because you had somebody check that off first before you gave it to them.
Well, they're checking off that you have 4 units in the syringe. They're not checking off my patient's blood sugar was 240 and their sliding scale calls for 6 units. They're just checking off, yep, I see 6 right there, we're good. That's all. And then they're also not checking off that you walked into the right patient's room and gave the right patient the right med. Yes, ma'am.
So for pre-diabetes, we're just assessing for signs of hyperglycemia. Type 1, still assessing for signs of hyperglycemia, like the poly.
All diabetes are going to have the potential to have hyper or hypoglycemia. Heck, even without diabetes, we have the chance of having a high blood sugar or a low blood sugar. If you ever get feeling real faint, and you haven't eaten well, your blood sugar could drop, but that doesn't mean you're a diabetic patient. So with pre-diabetes, we're primarily looking at what is our lifestyle? Where are we at? We may not have those specific symptoms. It is my hemoglobin A1C has come up and showed, it had told all my secrets that I do not eat right, I don't exercise, and my blood sugar remains high. It doesn't mean I'm going to have the 3 Ps. Yes?
If you're like a pre-diabetic and you start like exercising and eating right,
Mm-hmm.
like
Absolutely. Yes. Yes, absolutely. So what Leisha asked is, if you're a pre-diabetic and you start doing the right things, can it go away? Absolutely. Yes. That's the reason you get all the education and all the warnings of like, hey, you really need to start doing this stuff because it's about to get bad. With type 1 diabetes, unfortunately, you cannot make those changes and expect that. It's not, nothing's going to make it start producing. Okay, so type 2 diabetes. Very important to note, a risk factor is our abdominal girth. So greater than 35 inches is a risk factor. I'm not measuring myself. What this means is we're overweight, obese, advanced age, family history. I have hypertension, which can easily lead to other problems. Sedentary lifestyle, I like to sit around. History of gestational diabetes. So for us women, that's kind of a warning. If, when we were pregnant, we had high blood sugar. Later in life, we may have high blood sugar again. So if any of y'all had that, I didn't have that, thank God. That is a bonus. So this does not require endogenous insulin like type 1 does. This you can do oral, but it does not mean that patients will not have to be on insulin. So education needs to include what? What does the education need to include? Huh? Take your medicine. Exercise. What did you say, Jada? Well, it depends on the pills. That's mainly with the insulin. So now, okay, I'm a type 2 diabetic. I've been exercising. I eat right. I take my metformin. can I get off of any of that stuff? Will it go back down? Can I go back to being no diabetes?
That's what I was gonna ask.
Absolutely. Yes, you can. So, huh?
Only type 2?
Only type 2, because remember, type 1, we can't fix that. I mean, I guess I could probably get a new pancreas and maybe that go away, but today's medical care is really amazing. I'm sure they could do that. But with type 2, yes, I can get better. So we need to make sure that we also explain to the patients that type 2 just means that their body's not making enough insulin, that they can go back to not being a diabetic with diet modifications, exercise, and lifestyle changes. Okay, is that all that's on that one? Labs, hemoglobin A1C, 6.5 or higher is my ticket number. Less than 6.5 to 7 is really what we want, because that means we're not pre-diabetic. That means we're not even on the radar for the doctors. We're doing good, making the good choices. Fasting blood glucose, we want to make sure if it is greater than 126, we're typically looking toward the diabetes range, but will we make a diagnosis, bless you, with that fasting blood glucose? Will we make a diagnosis just based off the blood glucose?
No, we need to do that with the H1C. A1Cs.
But what if I have 2 that are high?
Then they will order more tests.
Okay, so which test makes the definitive? The A1C, yes. That test is what's going to help make my diagnosis. So okay, yeah, go to the next. Wait, is there anything highlighted on that?
Glucose level, higher the A1C.
What did you say? Oh, yeah. So higher the glucose level, higher the A1C. Remember that one. Hypoglycemia and complications of it. So with hypoglycemia, it means that my blood sugar is too low, and there are different things that can cause that. But I need to focus on my signs and symptoms. So what are the signs and symptoms for low blood sugar? Fatigue, faint. What did you say, Anna? Extreme hunger, maybe like some nausea, more on my gastro stuff, because it's low. Think of low blood sugar. High blood sugar, yes, I'm starving and thirsty.
Nauseous, tremors, shaking.
Nauseous, tremors. If I got tremors, what else is fluttering around?
Your heart.
What do you got, Caitlin? Huh?
Blurred vision.
Blurred vision. Palpitations.
Confusion.
Some confusion can happen. Can kind of get a little foggy. Okay, so cold and clammy needs some candy. Is that what Ms. Baker told y'all?
That's funny.
Okay, well, cold and clammy needs some candy, because that is when my blood sugar is too low and I need some sugar. So what is highlighted on this one is, oh wow, hang on, let me take this one out so I can look at it. I got a lot highlighted on this one, actually. Huh? Okay, good. So, management. Your patient is awake, alert, and oriented. How am I going to treat their hypoglycemia?
Candy.
Orange juice.
Candy, orange juice,
Butter.
Small meal. Honey.
the sugar tabs. What about like a regular soda? Ooh, what about honey? Yes, honey would be a good one. How much? Like a tablespoon? I'd go with a tablespoon.
Put it in the mouth.
How much juice?
4 to 6 ounces.
4 to 6 ounces. Yep. Now, okay. I like orange juice, but I'm in kidney failure.
Apple juice.
Let's try some apple juice. There you go. Good job, Carlos. So if your patients have kidney problems, orange juice will not be their friend. Well, remember, it's very acidic. It's also high in potassium. So if my kidneys are not filtering, then it doesn't necessarily filter things out either. So how long are you going to wait to recheck my blood sugar?
15 minutes.
Very good. 15 minutes. What is considered a low blood sugar? So at what point am I thinking?
Less than 70?
Less than 70. Good. Is hypoglycemia more common in type 1 diabetes or type 2 diabetes? Okay, if I were going to give somebody graham crackers, how much would I give them? Yeah. 3 graham crackers. Another option that I could give somebody in the hospital, if they cannot take the tab, is what other form of glucose? IV. Yes, so you can give glucose IV. We do not teach patients to do that at home. Do you need to be concerned with giving the glucose in the IV? Yes. What size IV do I want? Have you ever seen liquid glucose?
So like a 20?
So it's very syrupy. So you're going to want 20, maybe 18, preferably 18. You don't want to. And I get that you may have options that this is all I have. So guess what you get to do?
Dilute it.
You get to do you cannot dilute it. You cannot dilute glucose. But you do get to use some critical thinking and maybe even a friend on how to administer this giant vial of very thick syrup into this little IV. One thing that we have done before is someone will draw it up into smaller syringes. So you draw it up into smaller syringes, you're giving it smaller doses. What do you think are some risks that can occur if an infiltration happens when you're giving them IV glucagon?
Swelling?
I mean, yeah, you're going to have some swelling, but...
You have to give them the med again because you didn't give it to them properly, so you're going to have to like recheck their blood sugar because you don't know how much ended up actually going in if like it infiltrated at a certain time, and you're going to have to like redo the whole process of thinking.
Yep. Possibly. But what's the risk of where that infiltration occurred?
Infection. Bacteria.
So we got infection, we got bacteria, we can ultimately go to tissue damage. So it's not the easiest thing to give IV. It is possible. You want larger gauges and you don't want to slam it in. Because in the event that you infiltrate it, and picture this, you infiltrated but didn't realize you were infiltrating until you've already given, is it 30 milliliters? 50 milliliters of glucagon. So, true story. Young person came in, and because they have multiple comorbidities, blood sugar dropped. IV was a 22 in the foot.
Oh.
End result was person lost their foot because it infiltrated while given the glucagon and nobody caught it. So that is not good. Okay, so remember to be very careful with that. So we really like for our patients to be awake, alert, and oriented so I can give them some terrible tasting glucose tabs or some juice, right? Yes?
Is it still gonna, like, is glucagon gonna, like, burn? Like, you know, when you, like, liquid
It could burn.
Mm-hmm. So it would still burn?
Yep. It hurts. And it really, even when you're trying to do the smaller amounts, because, I mean, you're trying to shove syrup in there, really. It's very thick. So, yes, Armando?
Is there any way you could like warm it up, like so that way it would go in easy?
No, because then if I put it in too hot, what's going to happen?
Burn.
I know, now I'm going to burn the inside of the veins.
Yeah.
I know. I mean, but you know what? That's a great question. So how does evidence-based practice start? With fabulous questions. So you research that, try it, let us know how it goes.
Try it.
I mean, like, figure out a way to do it, right?
Okay, I've got a question.
Heard her say it.
I've got a question. I mean, basically, you're putting, like you said, syrup in there. If you were to make a simple syrup, which is just taking sugar and boiling it in water, that can be thinner. I mean, why does it have to be so thick? I mean, can't
You know, that's a great question.
make it thinner?
That's a great question, and unfortunately, I don't really know the answer to that because I don't know the compound of the drug. So that would be like taking this back and drilling down to what's the compound of the drug.
Why can't they mix it somehow somehow with some kind of safety.
So there's your evidence-based practice right there. You're on that, Julia. That's your research to do right there. Yes. Because I don't know. There's so many things that I could ask those questions for and be like, yeah, why can't we do that? Because why can't we do that? So, why can't Siri understand everything I tell her?
Right. People and AI.
Yes. Okay. What else do we have on that one to cover? I think we got most of that one. Okay, next one we're going to move up to hyperglycemia, which is
Too much sugar.
too much sugar. It's too high. So this is where my 3 P's come into play, because I'm routinely have high blood sugar, so I got to pee all the time, I'm thirsty all the time, and I'm starving all the time. I don't know about y'all, but I had that without being a diabetic. So, okay, 3 P's. So we're going to check our blood sugar. And what am I concerned about with my blood sugar?
Anything over 126.
How high it is.
Anything over 126, but I'm also really concerned with how high it is. I will treat them with insulin based off how high it is. If we do not get it under control, then we run into the chances of them having more critical diseases, such as, or it's not a disease, it's an illness, a complication. How do I want to say it? Yeah, it's an illness. So DKA or HHS, which is 2 things that y'all are going to learn about in acute care, because guess where you treat those at? ER and ICU. So those are not us. However, we do understand that if we don't get our blood sugar down, this is what it could lead to. Notice the signs and symptoms for hyperglycemia can also be similar to hypoglycemia. How do you know the difference?
Blood sugar.
Let me assess. Take the blood sugar. And I may not have I'm not cold and clammy. Yeah, with hyperglycemia, it's not cold and clammy, but I could have the blurred vision, the nausea, the vomiting.
You don't have the anxiousness, is the question. I'm not making a statement.
You can still feel a little anxious, but you don't have that, like I'm fixing to pass out. Yeah, it's different. Highlighted? No highlights on that? Okay, good. Okay, so chronic complications, because we understand that this does come with complications. Neuropathy is a nerve because it will deteriorate my nerves, so that means that my feeling sensation goes down. It's very important to check feet. Somebody recently had a patient that had a foot problem. They didn't know they had stepped on a nail. Who was that? There we go. It was Layla.
Quick story.
Wasn't that it?
So he had neuropathy, and basically a month before he was in the hospital, he stepped on a nail but didn't realize it. So because he couldn't feel anything, and so he got infected until his wife was "Yo, what's going on with your foot?" And so it was all infected and had a lot of purulent discharge and everything. And then I don't know because the day after, but they were talking about possible amputation. It was bad.
Well, guys, tell me.
No. So if
I
we
think he just stepped on it and
Yeah.
that.
Oh, okay. I was just picturing
This is
Home Alone.
Yes. They lose all sensation in their feet. So we teach them, do not walk around barefoot. Look at your feet every day with what handy dandy little tool? A mirror. Yep. Stick a mirror down there. We can't all. I can't do that very well. So, use a mirror and put the mirror underneath the feet so that way they can see in between the toes. Don't forget about that part. Wear shoes inside, outside, all the time.
With the white toe box area.
With the what?
Where your toe goes, it's called the box. You want it nice and wide. You don't want it form-fitting where you get blisters.
Yes. Wear shoes that fit. Let's go with that. Okay, now with my eyes, what type of physician do I need to get to know? An optometrist, yes. Because you can have, you can have the retinopathy, cataracts, glaucoma, blindness. You can have little bleeders, your little vessels can start bleeding. Different things can happen with your eyes. So we definitely don't want that to happen.
Cataracts can come from...
Yeah, diabetes. Uh-huh. They also come from just general aging, so you have to figure out which problem it is. But if you have if you're like type 2 diabetic, you're at greater risk, and even type 1 diabetes. Kidneys, that's another one that the diabetes can impact. You can eventually end up on dialysis. So again, managing all of the things, diet, exercise, med compliance, all the things that we want to make sure our patients understand. Next. It's all the same thing. It's all the same thing we just talked about, so let y'all go with that. Okay, here's a fun one. Cultural competence. How many, we have a variety of cultures here in the room. How many of your culture diets are diabetic friendly? Sort of. I mean, is it, okay, what's your culture?
Mediterranean.
So Mediterranean. Okay, I was going to guess, but I didn't want to assume. Jazz? Were you? Yeah, is yours diabetic friendly? Your diet, like from home.
Too much sugar.
From home. Your normal diet. Because you're what, Nigerian? So, okay, yeah. What? Yeah. Cheese Nigerian. So, what type of food do y'all eat? A lot of rice. Is rice? So we have like the diets high in rice. Like I've had some Nigerian rice. It's like one of my favorite things to eat. Yeah, the what? Yes. So, but okay, so we have the Mediterranean diet. That typically is a diet that a lot of people are going to follow because it doesn't have a lot of the carbs in it. So, what about y'all, Sammy? Or Sunny?
Rice, lentils, vegetables.
A balanced diet? So, is it Indian? Or is it? Huh? Nepali. Nepali. I always say that wrong.
It's like a mix of rice and then there's like veggies and then lentils and everything like in every lunch.
So you have a variety of different things. So you've got your vegetables and your proteins and your fibers. Good. I like Mexican food. I do, yes. Yes, very much so. But it's not very healthy. And the same thing with our American comfort foods. I mean, deep fried, we're in the South. We deep fry Oreos, candy bars, everything, right? So, okay. Now, knowing that, okay, y'all come back to me. Is it a realistic expectation for you to expect your patient to just change their diet based off what you tell them?
No. They never do.
They don't. So what do I educate that patient on? Or what question? What's a question I can ask that patient to start this conversation? Julia, what were you going to say? Huh?
I was going to say moderation.
Yeah. Yes. Partly. Rachel?
Would you be interested in talking about diet ideas or?
Okay, well, I got to make them interested in talking about diet. So what question am I going to ask?
What are you eating?
What do they like?
Hang on. Yes, Narissa? Did you lose it already? Okay, Karis? What foods do you like? That's exactly what I was going for. What foods do you like to eat? So that way I know, if I know what they like, I can then teach them how to modify that. So if I like white flour, can I possibly turn you on to some wheat flour? Or maybe discuss the portion control side of it. You get 1 tortilla instead of 5. So that's not happening either, but I mean, it's a good thought. This is engage the patient where they are, not where we want them to be. Yes, Armando.
So if they like gravy on everything, how do we fix gravy?
So half gravy. Cut them down, water it down maybe a little more. And again, we can go back to the flour that we're using. Am I using white flour? Can I maybe convert to wheat flour? Or what about gluten-free flour? But I will tell you for diabetics, actually take that away because gluten diets are not good for diabetics. Everything, it's really high in sugar. Yeah. Sorry, I can't. That came back into my head right as I was saying that. So scratch that. Okay. Any other questions about culturally competent? We're gonna fix to dive a little bit further into nutrition. Yay! Okay. Have them consult with a dietitian because those are the experts, right? I'm not an expert on dietary stuff. So I'm gonna have them consult with a dietitian. And then they're going to teach them what are some healthy fats, how much to eat of what, because it's all about portion control, balanced diet, a little bit of different things, not the same thing over and over, right? So some healthy fats are olives, nuts, avocados, minus all the other goodness that you add with the avocado, but still good.
Didn't they say all the oils that like stay the liquid form are the healthy?
All your oils that say are the healthy. And if you look at, because we talk about nutrition labels, read the labels. So what all is made up of things? Like butter. I mean, what's the difference between butter and margarine? Well, if you look at the labels, a lot. Because if you get just unsalted butter, butter's the only thing in there. So when you get margarine, you're factoring other chemicals, and that's what keeps it solid. So unsaturated and saturated fat. Which fat do I want to avoid? Saturated fat. Yes, good. So just reading your labels and understanding that is what's going to help. Carbohydrates, it does not say that we cannot have any, but we don't need to have a lot. Protein, a good source of protein with any diet. Lean protein, remember. Alcohol, we have to have in moderation and limit, again, our intake. Because of how alcohol affects our body, we want to make sure that we're still monitoring our glucose as well.
It's crazy how much carbs is in almost everything.
Almost everything, yes. I mean, it is, when you start really looking and paying attention, it's like we can't eat anything. Well, grass probably has carbs in it. Not really, I'm just kidding. So regular exercise, what's our key weekly? 30 minutes a day for 5 days, or 150 weeks per minute. Y'all are going to see that again, so that's kind of why I keep saying that. Huh?
You said 150 weeks per minute, but
oh yeah, y'all know what I'm saying. Y'all know what's coming out that ain't coming out. Okay, so we have monitor their blood glucose, weight loss, diet, exercise. Decrease their blood pressure, help increase circulation. Monitor their lab works. Do we have anything highlighted on that? I don't think so. Okay. This slide includes oral medications that you can take. So metformin is also known as glucophage. What is something I know about metformin and its relationship with my kidneys? Is it important? I mean, it is very important. Carlos? Now, come on. No, this was, yes, I know. Yes, okay.
Is it hard on your feet?
It is. They don't play well together. But what really angers them? Y'all say hi to the queen. Hi, queen.
Hi, queen. Y'all miss me? Yes. Don't be scared. Don't be scared of her. I left shirts outside your
Okay, let's go back on here.
Text you.
Yeah, don't be texting me asking if you can leave early. Okay, so back to metformin and my kidneys. Okay, so I'm in the hospital. I am having chest pain, and I need to have a heart cath done. In that heart cath, they're going to inject some dye into my vein, but I take metformin. Should I go straight to the cath lab?
No.
Should I discontinue?
Yes.
For how soon before?
2 days. 2 days. 48 hours.
Okay, so you're gonna hear a lot of things about this and the time frame. But what we would like to do is not give them metformin 24 hours before and them not take their metformin 48 hours afterwards. Okay, so before and after. Now, some of y'all heard my little saying in sim last week, and so some are going to know the answer to this. What happens if I'm having a STEMI and there is no time to hold my metformin? Are we going to skip my heart cath? No. That is the process where, you know what, we'll worry about that later. Right? We're going to treat it, and then we're going to come back and try to save my kidneys. Okay? So, with metformin, remember, yes, Rachel?
I'm a little confused because I thought people with kidney issues, because of being diabetic first and then now having a heart issue, you can't give them iodine. Or, the dye, you can't give them dye because of kidney issues.
How else are you going to know where my blockage is?
I don't know, but you can't give them. So what do you do in and out?
So what was the saying I said with y'all's group?
I forgot, I guess what's most important before they die.
Pause that. Okay, so yeah, that's kind of the way I think about like ICU stuff is, they have heart failure, but you got to give them a bunch of fluids. Well, let's give them some Lasix. So with this, but the important thing is because we're in chronic and we're med-surg nurses, next week we have a simulation for a diabetic patient. Just so happens they're going to need to have a pyelogram, so a kidney test done. So study up on your metformin, okay? Because we already know metformin and iodine or dye, any of the dye that they use, does not play well. The kidneys, it affects the kidneys. So you can hold it before, hold it 24 hours before, and educate your patients to not take it immediately after. You'll hold it for 24 to 48 hours afterwards, okay? Okay. We got any highlights on that? Y'all got any questions on that?
I do.
Yep.
Is the hold it prior and after just before a cath or like any procedure?
Any procedure that involves dye.
Okay.
I just use the heart cath because, I'm a heart girl. So, yeah. So, know your insulin. Know what's your peak time. What's the work time? So, rapid acting, what's my onset?
15 minutes.
Okay. Short acting?
30 to an hour.
30. So, if I doing some ACHS blood sugar checks. AC is before meals. HS is at bedtime. I ask y'all this all the time on your clinical documentation. So if I'm giving them their before lunch, I need to give them a couple of units. It's going to be rapid acting. How fast do I want to have that meal there? Right then. Okay, so what if I just give the short acting?
You probably want it right there because, just in case something happens.
I got it close, but I want it within 30 minutes or 15 to 30 minutes. So, but with the rapid acting, I want it right there. Short acting, I can buy myself a little time, not a whole lot of time. Long acting, am I worried about meals with long acting? No, I'm not. Because long acting, I'm going to give it, and it may be several hours later that it's going to actually start to work. Okay. All right, we can go to wait, there's highlight. What's that?
How do you store insulin?
Ooh, how do you store insulin?
In a fridge.
In the refrigerator.
Does it have to be in a fridge?
No. In the dark, maybe dark. Cool temperature, room temperature.
In the, what's it called? Certix.
So, before I open insulin, where am I going to store it at? Refrigerator. After I open insulin, where can I put it at? Room temperature. For how long? 1 month. Or, how many days is that? 30 days. So, we store it after it's been opened at room temperature. What does that say? Why is it room temperature?
So it won't deactivate any of the, I don't know.
Well, I mean, you're onto something there, Narissa. So the purpose of doing it at room temperature is to minimize tissue injury and to reduce the risk for lipodystrophy. Reduce the risk of it tearing something up, which is tissue damage. So you keep it at room temperature to minimize your risk of tissue damage. It kind of goes back to that hot, too cold thing. Oh, Armando. Too hot, too cold can impact how we're doing stuff. So, other things to know: regular short-acting begins working 30 to 60. Have your meals ready, or know how much time it's going to take you to get, or how much time you have to get the meal. Yeah, we covered that one. And here we go. Everybody loves wounds. Woohoo! So, foot care, daily foot care, making sure they're looking at their feet. Wear proper footwear. Don't run around barefoot. Okay, one more slide, then we're going to take a bio break. Okay, so Samoji effect. Anybody know what that is? Samoji. Not.
During in the nighttime. Decrease glucose during the nighttime.
Okay, so highlight all of this.
Oh.
Okay. So the Samoji, I mean, the dawn phenomenon is also something, but that's like whenever you wake up and you have high blood sugar. You just wake up with high blood sugar. But your Samoji effect is one of those things to where in the middle of the night, your blood sugar is going to drop and you're going to get hypoglycemic. So if you're concerned that a patient has this particular response to their, or happens with their blood sugar, I can't talk, then you want to wake them up between the hours of 2 to 4 a.m. to check their blood sugar, because that's about the time that it's going to be dropping. Now, we may or may not know that we're getting hypoglycemic in our sleep, right? So it's something to educate the family on your member. You may need to wake them up to check their blood sugar if it drops in the middle of the night to make sure they don't need anything to treat hypoglycemia. So that is the Samoji effect.
Okay.
So they never sleep.
Yeah, so they're constantly being woken up in the middle of the night to take their
From 2 to 4, heck yeah. You want to do that, or you want them to die from hypoglycemia?
No, I'm just talking about like, is this like a normal, is this like a occurrence type thing, or is this like, this is their normal?
This is not 100% of diabetics. It is common. I mean, I know an old couple that, yes, he would wake his wife up in the middle of the night all the time to check her blood sugar.
So in other words, you have
and it was,
have
yes. So, but it's something that you can't ignore. Rachel?
Is that the diabetic coma they talk about, where they go through?
It can be a diabetic coma, yes. Like your blood sugar is going to drop so low. Or could you get in a diabetic coma with it being too high too? Yeah, either way. Yeah.
Like a gel or something, or is that the IV?
For the, let's see. You don't want to put anything in their mouth because they can't really swallow. So if they're in the hospital, yeah, we'd give them something IV. But they're home.
Yeah.
That's a good question, Rachel.
No idea.
Talking about how to treat it if you wake them up and it's, like if they don't wake up. Yep.
Okay, this is gonna sound silly, but how do you know that you get to that point? Because I know that if once you know, you're gonna be checking it constantly. But how do you realize that you've gotten to that point where you're having low blood sugar?
Well,
so if you're waking up and you're like feeling bad, and then you're kind of trying to investigate like what could the problem be, this is one of the things that you can test the theory.
Oh, okay.
Yeah. What were you gonna say?
I was gonna say, my husband was a diabetic, and he was notorious about taking his insulin and then just eating steak. And that's it. So he would go to bed, and you're talking about how would they know? He would wake up in the middle of the night, and it'd freak him out because he could feel his body, the clammy and all that stuff, and then he would be like orange juice, candy bar, and it's like, honey, you've kind of gone too far.
Yeah.
Yeah, he would wake up.
Yeah, and that's how some people, they'll be like, oh, I keep waking up in the middle of the night and my blood sugar's dropping. So then this is whenever you come into this pattern, you start testing it, And it could just be a one-off, or it could be that they have this problem. Yes, Narissa?
There's nothing that you put in your like mouth that absorbs into your
I'd have to look. I'm not aware of anything, but that doesn't mean anything either. So I would have to look to see if there is something that would do that. Yes, Ashley?
People who have like high or low blood pressure are not like Dexcom.
They what?
Dexcom, like something to measure it often.
So they can. The Dexcom is something that measures, and there's tons of different products out there that will measure your blood glucose, and so they can do that. But if they have a pump, their pump is also measuring their glucose. But if they are, like, say, a type 2 diabetic, so here goes. I always pull my family into this stuff. So my brother-in-law wears the Dexcom, so he wears it on the outside. So there's no pump. He doesn't do any insulin, but he does know if his blood sugar is dropping, because then it goes straight to his phone. But your type 1 diabetics are going to want to have that with the pump. So then they don't need the separate thing. They have the pump that's attached to them and telling them. So yeah, that's an option too. All right, any questions? Yes, Jada?
The NURS, keep talking about the
So that talks about the synergy. That goes with the synergy, the Simoji effect. So if your insulin level falls too low overnight, your blood glucose will rise. So, well, that's the dawn phenomenon. So the dawn phenomenon is overnight, my insulin goes down, so then my blood glucose goes up, and then I wake up with a high blood sugar. So it's kind of like has an alternative effect. So let's say, I'm going to use your husband as our example. So let's say I did my insulin at night, or no, I didn't do it at night like I normally do. So I took it at 6 p.m. So then I went to bed about 10, and after a little while, my insulin's going to stop working. So by the time I get up at 8 o'clock in the morning, it's a nice life, right? So I get up at 8 o'clock in the morning, my blood sugar is now high because my insulin that I took at 6 is no longer in my system. Does that make sense? So because the insulin has stopped working, I no longer have that insulin, the glucose is coming back up. Yeah. And that's it. That ties into the dawn phenomenon. Yeah. Any other questions? No. Okay, so let's take a bio break because y'all been sitting here for a minute. Talking for a minute. Seriously, are you timing it, Priscilla?
Not that I'm timing.
All right. So, metabolic syndrome. Now, I've already told y'all I am not super familiar with this, and I am fixing to be honest, as that Lisa and I were just, or Miss Fraser and I were just discussing it, and she's not familiar with it either. So the fact that she's an ER nurse and has been for a long time makes me feel really good. This is not something that we're going to commonly see. However, it is part of the endocrine that is a malfunction that we're going to share with you. Looking at the risk factors, you have genetics, age. What's in orange here? Central and abdominal obesity. So what's the abdominal girth that we're worried about with diabetes? Greater than 35. So we're going to pull that in here. And then criteria for having this is 3 out of the 5. So you have the abdominal obesity, you have the high blood pressure, high blood sugar levels, triglycerides, and low HDL. So, I mean, how many patients is that we see that could be at risk for this?
East Texas, it's a lot.
That's a lot, yes. That's the majority of the population right there. So, considering that it's not a common diagnosis, I'm like, okay, that's kind of cool. So, something neat. Treatment for this, you have medications for your symptoms, like your blood pressure meds, diabetic meds, and bariatric surgery is the big treatment for this option. Because what do you do to get the weight off and to help get you healthy? So, yeah, you can do all the lifestyle changes, but the bariatric surgery is like the for sure thing that's going to help with this, in addition to the health changes. So for this, and this is just my interpretation of this, don't take it as the gospel, but I'm thinking these are like the obese of the obese. Like our 300-pounders, our 500-pounders. Did you say Tammy?
That's her name, Tammy and
Crazy.
the sister.
Oh, my 1,000-pound life or 600-pound life or something? Whew, Lord.
I thought she was saying Tammy.
Listen. We got we got a couple of Tammys around here. That's why.
Bro, alright.
Okay, let's come back in. But yes, just like them, this is our morbidly obese patients that you will see in all the area hospitals. We even have them here. So, all right, last slide. This is your treatments and your therapies. Lifestyle changes, the bariatric surgery, because this is something they need to lose a large amount of weight to fix this. Meds for diabetes, high blood pressure, cholesterol, whatever other symptoms that you're managing, basically. There's not a specific med for metabolic syndrome. You're going to treat your symptoms of it. And CPAP. So because with this weight, breathing at night is typically a complication, because when you lay flat, all of the fat lays flat with you, okay? All right. And the last one. Questions, concerns, thoughts? I was going to do a game today, but I think we're going to skip the game. Are y'all okay with that? What's the answer to the SATA? Oh. So the metabolic has a lot of notes. So like all of these pages are the notes in the metabolic. Well, I mean, it's all of the content in one. But that's also it's everything from ATI. So providing, are y'all listening to the SATA?
Settle down.
Who can whistle? Who's got the loudest whistle around here? Do it.
I'm ready to go. That's why.
Yeah, yeah. Okay, so yes, Julia.
Is this metabolic syndrome, is that kind of a new diagnosis?
No, it's old. Just because it's not widely known doesn't make it new.
Well, that's why I was wondering if that was why.
No, it's an old one. It's just not something that we address every single day. We typically are just going to focus on all the symptoms, but we have patients that probably have this, and we don't refer to it as that. Yeah. Okay, so the SATA question is, providing a teaching to a client who has metabolic syndrome, the nurse discusses diagnostic testing results that are outside of expected parameters. Which of the following conditions does the nurse identify as risk factors for the development of metabolic syndrome? Your options are A, hypertension.
Yes.
Yes. B, obesity.
Yes.
Yes. C, hyperthyroidism.
Yeah.
No. No. D, hyperlipidemia. Yes. E, hypoglycemia. No. So we have the answers for that one are A, hypertension, obesity, and hyperlipidemia. Hyperthyroidism, typically patients are already thin. Yes, like really thin. They run around circles around us. And then hypoglycemia is simply a symptom of diabetes. So it's the bigger thing, the diabetes. Okay, another question is metabolic syndrome can cause which of the following conditions? Ooh, that's a good question. So, is it A, dementia?
No.
I don't think so. No. B, cancer?
No.
No. C, non-alcoholic fatty liver disease?
Yes.
Yes. D, pneumonia?
No.
No, not likely.
You don't think so?
Well, I mean, I guess yeah.
I mean, sedentary lifestyle.
A sedentary lifestyle is where your risk factor is there. Huh? I wouldn't pick that as if that were a test question. I wouldn't pick pneumonia. But I would definitely pick the fatty liver and the last option, diabetes. Diabetes and fatty liver are the two. I would go with that one. Okay, so that is all the content for today. You know what? Next week maybe we'll do my game as a refresher to see what y'all remember.
I know.
Okay, questions about your SimWars project?